Hello, good afternoon. My name is Steven Jonneau and I'm a urologist from Leuven, Belgium. I'm here at the Royal Society of Medicine in London, and I was invited to talk here about new developments in the treatment of high-risk prostate cancer and oligometastatic disease. What I want to share with you here is some new developments on the latter, the treatment of oligometastatic disease. And mainly not the primary oligometastatic disease state, but the oligometastatic recurrent disease state. And we have some data, some nice data from Europe, coming from a couple of centers, Germany, Italy, and also our own center in Belgium, where we have looked at patients with a rising PSA mainly after surgery, and the majority of these patients also had received local radiotherapy to the prostatic fossa, but then developed PSA recurrence, and we used whole-line PET-CT and also are using since 1.5 years PSMA PET-CT scans in these patients. And the first scan, the whole-line PET-CT scans in these patients, they seemed in the beginning, we were quite thrilled because we could see in many of these patients oligometastatic recurrence, usually and very often in about 2/3 of the cases in the nodes. But after counseling these patients and taking the nodes out, we didn't only take the nodes out, which was shown on the scan, we also did a template resection of the pelvis, and in a couple of these patients, or a number of these patients, also the retroperitoneum. We were a little bit less enthusiastic, or we became a little bit less enthusiastic about the value of whole-line PET-CT. Why? Because there was a very high false negative rate of all the nodes that were found positive on histopathology. 75% of these were not seen on the pre-op whole-line PET-CT scan. So there was a very high false negative rate. And then the other way around, there was also a pretty high false positive rate of around 40%. So in the end, the accuracy of the whole-line PET-CT in correctly staging patients with recurrence after local treatment was not extremely good. So two conclusions could be drawn from this data. Is that first, whole-line PET-CT, although better than any other existing imaging at that time, being MRI or CT or bone scan, being better, it was still not good enough to correctly stage those patients. And secondly, if metastasis-directed therapies are considered in such patients, you should go for a template dissection, because you will find more nodes than you see on the scan. And same goes for radiation oncologists. If they consider irradiating these nodes, they should also irradiate the template around these nodes, maybe boosting the nodes. Then more recently, we've been using PSMA PET-CT scanning for the same purpose, for the detection of oligometastatic recurrence when the PSA starts to rise after local treatment. And what we found is that the threshold PSA to accurately and confidently detect metastatic disease was much lower than whole-line PET-CT. There, whole-line PET-CT, the threshold is typically around 1.5 minimal threshold. With PSMA PET-CT, we found that the threshold for finding positive signals on the scan was 0.45. We have presented this data at the EAU. It was well received at the EAU. We also saw that patients with a lower PSA than 0.4 or 0.5, that the PSA doubling time, if it was less than 6 months, it was also strongly correlated with positive PSMA scan. So PSMA PET-CT immediately to us appeared to be better and clinically deliver more relevant information than the whole-line PET-CT scan, and we immediately stopped using whole-line PET-CT scan. We're not using that anymore. And now we're analyzing the same in a salvage LND, resections. Salvage LND is in patients with nodal recurrence. We see a better accuracy of PSMA PET-CT, although still it's the tip of the iceberg you see. the staging accuracy is better, but the recommendation of doing a template dissection or a template treatment, if you would go for radiotherapy, remains. And so clinically, the endpoint is similar, but at least we're treating much less patients with a positive scan who have in the end no positive nodes, which we did when we used colon PET-CT scan. There's a number of prospective studies that are running and that we have set up and submitted for grants. And some of these studies will study the adding value of giving hormones and or radiotherapy after salvage surgery. Others will look at if we clear the pelvis and there's nodes positive in the common iliac regions, what the value is of giving a prophylactic radiation to the peri-aortic regions, because if patients recur after salvage surgery for positive nodes, if they recur, 2/3 of these patients will recur again in the nodes just outside of the borders of the resection of the salvage template. So the jury is still out what the exact value is of colon PET-CT and certainly PSMA PET-CT. We know PSMA PET-CT is better, performing better, but then the value of targeting metastatic lesions by surgery or radiotherapy over the classical hormonal treatment or a wait-and-see strategy is still, the jury is still out regarding this. So we need a couple of more years and then we'll know the results of that. Thank you very much.